Alrighty, I think we left off here, and I believe we answered this question, right?
We did.
Yeah. All right. Oopsie. Okay. Okay, so again, we're still finishing up on schizophrenia, so we have to look for if they have any medical problems. There are some medical problems that can mimic psychosis. There actually are some psychotic symptoms that people can have with different medical issues, especially thinking about side effects to medications. So sometimes people can have a psychotic episode related to the side effect of a medication. And our elderly people are, of course, very prone to this. And they can become psychotic even after surgery, undergoing anesthesia. Some pain medications can cause psychosis. So we always have to look and see if there are some underlying medical issues. And, of course, brain issues, too, stroke, different things like that. We always want to look for drug and alcohol use disorders because they are very common with people that have schizophrenia. And sometimes people that use illicit drugs, that can actually be the thing to kind of tip them over the edge into psychosis if they have that genetic predisposition. So patient once said he went to a party and he just used all kinds of drugs. He doesn't even know what he used. Have you ever heard of a farm party? You ever heard that terminology? Farm as in P-H-A-R-M, not F-A-R-M, not as in cow farm.
Okay, that's what I was thinking.
No, farm as in P-H-A-R-M. And apparently people just mix bunches of pills all together and you just take a handful. You don't even know what you're taking.
Ridiculous. It's like a bowl that they just dump.
Right, exactly. So pretty scary. So this guy was taking all kinds of drugs that night in addition to the handfuls of whatever. And so he actually ended up developing schizophrenia after that party. So, yeah. So drug and alcohol abuse, drug abuse especially, can be very much something that just, tip that brain over the edge into psychosis. We're always doing a full mental status exam, so we're looking at it's kind of like a head to toe, but a mental head to toe. So you're looking at their appearance, their behavior, their thought processes, their mood, their motor behavior, if they're pacing or if they're not doing anything, if they're catatonic. We're looking for hallucinations, delusions, if their thoughts are clearly expressed or not so much. So we're just always doing that full mental status exam. And a cognitive assessment to see if they know what's real and what's not real. It's interesting this week, we did not work with a person, but we did have a patient that had some, catatonic symptoms this week. So we just saw a little bit, Katie, right? She was kind of standing in the hallway, kind of mute at times, but did end up starting to respond to medication, so was starting to at least whisper and talk and verbalize a little bit to the nurse. But basically was the day before, I think Monday, when I had gotten there to make out assignments, just like standing in the hallway and staring and just standing there for long periods of time, not taking care of ADLs and things like that. So we definitely see some interesting aspects. So we're always assessing for hallucinations. And what's the most important question to ask if you're asking questions about hallucinations? What do you really want to know when somebody is hallucinating? Okay, do you see something? Do you see something that's not there? Okay, and then what else do you want to know when you're assessing for hallucinations? Okay, are they talking to you? Yeah, actually, if you have a visual hallucination that's talking to you also, that's really bad. So sometimes people have just auditory or just visual, but if you have a visual that's talking to you, that's kind of bad. So what else do you want to assess for when you're thinking about hallucinations? What's some high priority? Yes? Yes, if the voices are telling you to hurt yourself. Or if the voices are telling you to hurt somebody else. And sometimes the voices actually even say hurt your nurse. Okay? So if the voices say hurt your nurse, we kind of want to know that so that we can take measures to protect ourselves, such as having security up on the unit, If people are having issues with either male or female staff, sometimes then we can try to adjust the assignment if possible to give them a male versus a female if that's what they would prefer. But we really do want to know what those voices are telling them. If the voices are demeaning, if they're saying, and they usually are, if they're telling them bad things about themselves, but most importantly, if they're telling them to hurt themselves or hurt somebody else. So delusions, so false ideas, and sometimes if you ask somebody, you probably don't want to say, are you delusional? Because first of all, they probably don't maybe really know what that word means. And they may just not say, oh yes, I've got this idea that I'm the king of China, They're not going to tell you that, but sometimes if you just have a conversation about something else going on in the world, maybe, if you ask them about, gosh, there's lots to talk about when you think about the political climate or just something about our society or the weather or sports, any kind of neutral type of topic. Well, politics isn't neutral. But anyways, so in case you're thinking I'm thinking it is, because it's not. So just engage them in a general conversation. And sometimes by doing that, it'll come out. So you can elicit some psychotic, delusional content just by having a normal, ordinary, everyday conversation about anything. Okay? So kind of keep that in mind when you're wanting to assess for if they're still delusional. Again, that suicide risk, personal health and safety. Many times people don't take care of themselves. Assess their prescribed meds. Are they taking their meds? Do they have any medical meds that they should also be taking? Again, it's kind of a nightmare when somebody has schizophrenia and they have diabetes or some other chronic condition and they have to take care of that. In addition to, it's hard enough to be, I'm sure, monitoring blood sugars and trying to keep on a diet, count your carbs, whatever. Can you imagine counting carbs and having to adjust your insulin if you have schizophrenia? Not going to happen really well. And just their general functioning. Are they able to hold down any kind of a job? Are they able to function, appropriately at all? And of course, the family knowledge. All right. So I think this leads back to that other. It's kind of an ongoing, little case study that they had in this PowerPoint. So the psychiatric nurse conducting Eric's assessment believes he's also suffering from command hallucinations, and we just talked about that. So we want to ask if the voices are telling them to do something, and if they feel driven to listen to those voices. So did I tell you about the person who was driving and they were coming up to a red light, and then the voices were saying go, 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 and they were going right through the stoplight? No? Okay, well, that's an example of what we want to assess for. So can you imagine you're driving along, you're hearing a voice that's saying go, 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 but you see a red light and you go because the voices are telling you? That's how powerful those command hallucinations are. So, all right. So some nursing diagnosis we could use for the positive symptoms: disturbed sensory perception, because again, all 5 of the hallucinations deal with our senses. Risk for self or other directed violence, and certainly impaired verbal communication. Negative symptoms: social isolation and chronic low self-esteem. So many people just hang out in their apartments and they don't do anything. And then the more they hang out by themselves, they start to get depressed. They start to get more paranoid and then more fearful. So it just kind of builds on itself. And they really don't feel very good about themselves because they, on some level, get it that they're not functioning the way that other people are. Or they might even be hearing that from their family members. Their family might be frustrated with them because they're not able to work and they're not able to take care of their own apartment appropriately, or even just do their own ADLs. So in that acute phase, hospitalization, stabilize them with medications. The second phase is trying to help them to understand their illness and control or cope with symptoms. There's actually quite a few ways that people can cope with some of their symptoms, like hallucinations. Do you know of any ways that people might try to, I think the book kind of covered that a little bit, any ways that people can use to actually deal with hallucinations? Because sometimes we hope the medication gets rid of them, but sometimes they're still kind of there. And they might be less intense, but they may not be as, they may not be as loud as they were, but they're still there. So how can a person cope with that? Any thoughts? I'm sorry, what? Okay, so you're talking. Okay, so you're talking about just having that awareness and being able to maybe say to themselves, this isn't really happening, this isn't real, this is a hallucination. That is actually something that is very helpful if they can do that, if they can distinguish that. Yes, yes, definitely. That is definitely a very helpful thing. Other people try very creative things like putting headsets on. For some people, listening to music is great. It really helps them to focus off of the hallucinations. But for some people, listening to music makes it worse. Or watching TV, again, might make it better, but it might make it worse if then all of a sudden you feel like the TV's talking to you. So it really kind of depends on the individual person and what helps them. So sometimes I read an article where it talked about like, if they just like take a phone and they just like, they're talking to the voices in the phone and then they kind of put the phone down and then they're like, okay, I'm done. So they kind of will pay attention to the voices for certain time periods and then they just say, I'm not paying attention to you anymore. So again, more of that self-talk. So little creative ways. There are creative ways to handle all different types of things. I used to work with a nurse who was very creative and worked with some people with chronic schizophrenia. And one day this person did not want to eat their soup. They were saying, nope, there's ghosts in my soup. I'm not going to eat my soup. And so he said, just eat around the ghosts. It worked. Person started eating their soup. They were eating around the ghosts. So, sometimes you just have to work with some of their symptoms. So we want them to try to get some control over that. Hopefully the medication will provide a great deal of stabilization. And then in that maintenance phase, we really want them to keep their level of achievement. We want that to prevent relapse and from getting all the way back down into a full-blown psychotic episode again, and to be somewhat independent and just have that good quality of life. So after an acute admission, discharge is being planned for Eric. What are some things that need to be considered? So what do you think? What are some important things in the community for somebody that has schizophrenia? Yep, having a routine. Support people, absolutely. It's very important. And even if they didn't have family, perhaps, there are support systems in the community. In Sheboygan, they have something called the Open Door, and that is a place where anybody with any chronic mental illness can go and just hang out and just be accepted. They have classes for them. Sometimes they teach them how to make different dishes based on stuff that they typically get from food pantries, which I thought was kind of creative, because instead of teaching them how to make this wonderful recipe, and they're probably thinking, well, I'm never going to have access to those ingredients, they teach them how to make typical things with probably, the typical things that you get from a food pantry. And they have like pool tables, and they socialize. They have different types of activities, arts and crafts. And so it's a place they could just go and be themselves and hang out with other people that have illnesses. So there are supports out in the community. It's just that we have to make people aware of them, because not everybody has family or friends. Maybe their family or friends are in another state. Maybe their parents maybe they're older and their parents are even gone. They don't have any brothers or sisters. So we always have to think outside the box a little bit for support systems. And then just hopefully that they really understand their illness enough to be compliant with their meds, because that really is a big, big, big issue, is compliance. So, all right. So we want to make sure, again, people are safe, and that that education is very important, and relapse prevention skills. So trying to help people, because they lack cognitive skills, it's hard to help them to plan, like, in anticipation of, like, such, so if this happens, you would do this. That's a really hard thing for them to connect. So that's the type of thing that we need to kind of be working on. So, all right. So we're going to be doing a full evaluation, support, psychoeducation, supervision, and limit setting in the milieu. So what's one thing that we do sometimes to limit set in the milieu? So, yes, definitely. Because that makes people, it might seem like it's kind of mean, like you're limiting them. They can't ask for anything except once an hour. But it actually gets them to work on their planning skills a little bit. So they have to kind of plan and think ahead about what they're going to need and anticipate their needs a little bit, rather than just spontaneously and impulsively asking. So yes, definitely. So having that routine and setting some limits appropriately that way. How about, have there been people that you guys that have been in clinical, have you seen people that are just restricted to certain parts of the unit, right? So they might be east wing, north wing restricted so that they can't just roam aimlessly all over the unit, because perhaps that is something that is not helpful for them. If they're very delusional and they're invading other people's space, then we want to kind of keep limits on that until they get a little bit better. Monitoring that fluid intake again, because we want to make sure that people, if you suspect, if you're in clinical, you suspect somebody's getting that water intoxication, they're drinking excessively, we really want to keep tabs on that. So we do see that from time to time. And then working with aggression, regularly assess for that risk and take safety measures. So there was somebody who was kind of aggressive on the unit. I'm not sure what her diagnosis was. The young girl who was like walking around and all of a sudden she'd like pound the wall, and she was bouncing the ball the other day. I don't know what her diagnosis. Do you remember, Katie, from?
That was when we were on break. That was when we were on break.
Oh, so you didn't hear the pounding and you didn't see that.
All
okay. So we do want to try to help people to work with their feelings, but we definitely want to keep themselves and everybody else safe. Okay, so again, medication adherence, a relationship with a trusted care provider, teamwork and safety. Activities and groups might be helpful for people to increase their social skills, but again, you have to be really careful. They may not be ready when they're just acutely psychotic and they're invading other people's space and they're intrusive. They may not be ready for a group, because the group is going to react negatively to their behavior, and then that puts them at risk for other people perhaps hurting them or feeling like they want to hurt them. So we have to be very careful about activities and groups, and when people are more socially appropriate, then that might be the time to do groups. Otherwise, the activities therapist would work with them on a one-to-one basis. So communication techniques. So when somebody is hallucinating, they're seeing something that's not there, what do you think is the best way to approach that? How do you talk to somebody who's having a hallucination? Mm-hmm. See if they can focus on you. And yes, give them information, give them factual information, tell them who you are, but very simple, right? You're not going to be blah, 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 blah. You're going to be very simple, direct, concrete. I'm so-and-so, I'm your nurse. And is it okay to tell them that you're there to keep them safe? Right? That you're there to help them? Yes, that is absolutely okay. Is it okay to say something like, well, you're not really seeing anything? No, we really can't do that. We can't argue with them about their hallucinations or their delusions, because it's real for them. Okay? So, did I tell you about when I record my lectures and then I'm like, did I say that in this class or did I record it? But the person who had a first episode of schizophrenia, young man in his 20s, and he was yelling kind of loudly. The student was going down there and giving him his meds. Well, we thought he was okay to work with because they told us he was fine. So student went down there to give him his meds, and then hightailed it right back up the hallway because the student got right outside his room and he said, you're going to get killed. Go away. You're going to get killed. Did I tell you that one? Okay, good. I don't want to repeat myself. If I ever repeat myself, will you guys tell me? Like, Mary, you've told us that before. I don't want to hear that again. So of course, student gets outside the door. He says, go away. You're going to get killed. So, of course, student leaves. Right? Best thing to do. Best thing you can do. So she came and got me, and I was like, okay, I'll go with you. So, and those were the days where we just took the medication and a cup of water. We didn't have to take the whole computer, thank goodness, with us. But anyway, so we, again, got outside in the hallway, right outside his room. He said, go away, you're going to get killed. And then I kind of looked in and made eye contact with him. And he didn't look like he was threatening in his eye contact. He didn't look angry. He really looked scared. And then, so I stood there for a minute, and then he talked more. And he said, don't you see there's dead bodies all over my room? There's guys outside my window with guns. And so he really truly saw that. So I went in, so I took the student with me and I took the meds at that point. So I thought, well, shoot, I can help her out a little bit here. So I went like this and stepped over the bodies. No, I didn't. I'm just kidding. You don't do that. But I walked into the room and I said, very concretely, like Sandeep was saying, told him who I was, and I said, I know it's real for you. I understand that you see this. I don't see it. Here's your medication. It'll help. Couldn't take it fast enough. So sometimes if you're just very reassuring, matter of fact, you have to acknowledge that it's real for them, but you also want to say, because it helps them with their reality testing, if you don't sound like you think it's real. Because if I truly did like walk around the bodies and say, oh yeah, look at those guys out there, that would not have been therapeutic at all. That would have just reinforced his misperception of reality. So, but I can't argue with him and say, no, there's nothing here. But I can say it's not real for me, but I understand it's real for you and that you really see this. Okay, so that's a really important communication technique to think about when somebody is hallucinating. And again, like Sandeep said too, you want to kind of get them to focus on you. Is they may be really distressed about something that they see, and he took the medication really quickly, but it's oral, so it didn't work really quickly, so he was still continuing to get very, very agitated about the guys outside the window with the guns and the bodies all over his room, so they ended up giving him an IM, but we let the staff take over at that point, so because that's just kind of beyond our scope to give an IM to somebody who's highly upset like that, but he did get better with the medication. So, yeah.
Via IV, do they restrain and put an IV in and then give it to him? Or because I know that's nobody had an IV given.
Right.
Which is understandable. It could be a safety.
If anything, it would be, well, we do give IVs for people that are going through withdrawal many times if they need like magnesium or potassium. So we do use IV therapy on the unit sometimes, or they might be severely dehydrated and they'll run a bag. But somebody who is acutely psychotic like that and acutely agitated, they're not going to do it by IV. It would be an IM. Yeah, it would definitely be an IM. There's plenty of IM preparations and different antipsychotic meds that you would give.
So somebody, if they're going to withdrawal and they could be a danger, obviously if they're going to withdrawal, somebody sit with them if they're on an IV?
Oh, if they were acutely suicidal, yes, absolutely, yes.
So it'd be like a one-on-one because there's
yes.
safety.
Yes, definitely. So, all right. So, if somebody's delusional, you can't talk them out of their delusion, but you can at least express doubt. So, one of those therapeutic communication techniques on your list of 18 pages of techniques is kind of expressing a little bit of doubt and saying, did that really happen, or do you think that could really occur? Just to get them to think again about the reality of their thoughts. It may get them at least to question it and think, oh, maybe that isn't quite real. But delusions you can't talk people out of. They are very, very firmly fixed. But we definitely don't ever want to argue with somebody with their delusions and tell them, no, you're wrong, that's not happening, because they really believe that it is. So, all right, that's, I think, all I'm going to say about that. So medications, we need to talk about those meds that help with people. First, second, and third generation antipsychotics, and then again we have injectables that are short-acting for somebody who's acutely dangerous, and then we have long-acting for people that have trouble with compliance. So maybe they only have to get an injection every 2 weeks or 3 weeks, maybe even some of them last a month. Much better than having to remember to take a pill a couple times a day. All right, so the first generation antipsychotics, Thorazine was the very first one that they developed, and that targets all the first generation ones. They just target the positive symptoms of schizophrenia. So they do not target the negative symptoms. So again, what's the difference between the positive and the negative symptoms? So we just talked about a couple of positive symptoms. We were talking about delusions and hallucinations. Any negative symptoms that you remember from last week?
Social isolation.
Mm-hmm. Okay, isolating themselves socially, and the negative symptoms are very similar to another major mental illness. Depression, right? So it's that apathy, that avolition, that get up and go is missing. They don't want to do their ADLs. Okay, so all those types of things. So they don't do anything with those symptoms. They just target those delusions and hallucinations and the impaired thought processes. They're less expensive than the second generation. They've been around for quite a while. The disadvantages are extrapyramidal side effects, anticholinergic side effects, tardive dyskinesia. Okay, also weight gain, sexual dysfunction, and endocrine disturbances. So the EPS and the tardive dyskinesia are very serious side effects. So has anybody ever seen anyone with they thought had maybe some tardive dyskinesia? That's the long-term effect. I hope not. But sometimes if you work in a nursing home, you might see somebody that's been on antipsychotics for a long time, and they may have some tardive dyskinesia symptoms. There's been a few patients recently on 1K that have had some tardive dyskinesia, some lip smacking, grimacing, eye blinking, those pill rolling, all those long-term effects. The extrapyramidal side effects are more like immediate, and those can be reversed very, very quickly with medications like NIM of Benadryl or Cogentin. Very quickly reversed, like within 15 minutes or so. But it's pretty scary. The EPS are very scary for a patient to go through because all of a sudden their neck is twisting to the side, their muscles get really stiff. One person had it so bad where her neck was twisting to the side that she had trouble breathing. So we really had to get her an IM very, very quickly. Their eyes can roll back, oculogyrate crisis. Okay, so their eyes roll back and get kind of stuck there. I had a very intelligent patient once, know everything about the brain and knew all about his schizophrenia and all about EPS. And so at times when he would get EPS, he would just go barreling down the hallway, screaming, oculogyrate crisis! It was like, oh my God, how can he even see to go barreling down the hallway? So we had to quick get the medication, corral him, get it, okay, here, we'll give you the med. And very, very uncomfortable symptoms for people. So very, very stiff, rigid, and that's reversed really quickly with, again, Benadryl or Cogentin. The, anticholinergic side effects, yeah, we get those with a lot of meds. You just try to increase fluids to the, not to the point of, obviously, of water intoxication, but hard candies that they can suck on, things like that can just kind of help with that. So, alrighty, the second generation, Clozaril is considered a second generation, although honestly, Clozaril is really used as a last medication that they will ever prescribe for somebody, because there are so many side effects that are really serious. And the side effects are very serious, and you have to do a lot of monitoring when somebody is on Clozaril. we've had a couple of patients recently on this, which is kind of interesting because I hadn't seen it for years and all of a sudden it's kind of coming back. But it truly is the last medication you want to order for somebody because the risk of agranulocytosis is pretty high. So we're constantly monitoring their white counts, and also the risk for severe orthostatic hypotension to the point where they're falling. Those are two really serious symptoms that we kind of have to watch out for. So when somebody's on Clozaril, they actually have to call the Clozaril National Registry and register that person, and they are in contact in terms of we have to report back to them if they do experience side effects, if they are experiencing orthostatic hypotension, what their blood counts are. They really do monitor that very closely. So you take orthostatic vital signs an hour before the medication. Okay, then you say you get the orthos at 8 o'clock, you give them at 9 o'clock, and then at 10 o'clock, an hour after the medication, you do another full set of orthostatic vital signs. Okay, because they can fall and hurt themselves very significantly with that amount of orthostatic hypotension. There's minimal to no EPS or tardive dyskinesia, but the disadvantage is it causes significant weight gain and that risk of metabolic syndrome, and now they're going to be developing diabetes. The weight gain, too, is the significant weight gain. We're not just talking, 10, 20 pounds. With Clozaril, sometimes it can cause 100-pound weight gain. So we're talking like really significant amounts of weight gain. Yes, there definitely are. I'm sorry, my cough is kind of coming back here. Yes, there are, and your book will list a bunch of other ones because there are more than just the Clozaril. So, let's see, what chapter are we on? Schizophrenia. Let's see. So what page did you say that was? Because there should be a whole list of... Okay, so Zyprexa, excuse me, second generation. Risperdal, Abilify, aripiprazole, yeah. Zyprexa. There's weight gain and there's different problems with all of these medications, but honestly, it's a matter of controlling the symptoms and getting that person a quality of life. And of course, we monitor, right? And of course, we monitor for those side effects. But yeah, we definitely are using a lot of second generation. Third generation, Abilify, Vraylar, I haven't really seen that one used. Rexulti, I haven't really seen that one used. But Abilify is actually a medication that we're seeing used a lot more also for people as an adjunct with their antidepressant therapy. So for some reason it helps the antidepressant to work a little bit better. So if you think about it, this would be excellent for people that have a lot of those negative symptoms. And they're having a lot of those depression-like symptoms. So this can be very helpful. So they improve the positive and the negative symptoms and some of that cognitive functioning. And there's little risk of EPS or tardive dyskinesia. So potentially dangerous responses to antipsychotics. So again, that anticholinergic toxicity, neuroleptic malignant syndrome. That is very rare, but it's very serious if they happen to get it. I've seen it twice in my 38 years of being a nurse, twice. So it is very rare. However, it's very serious. So they really get like lead pipe rigidity. So they are so rigid that they can't move. They have difficulties with their breathing. Their blood pressure goes really high. Their temperature goes really high. They need to be in the intensive care unit. They cannot be managed with neuroleptic malignant syndrome on a mental health unit. They need to be in the ICU. Okay? It is really very, very serious and life-threatening. Agranulocytosis certainly could be too. So that, again, we talked about that with the Clozaril and the need to be on that registry and having their white count monitored very closely. Some of the medications prolong the QT interval. Now, I'm not a med surg nurse, so we're not going to do med surg. We're not going to do CHA in here. But do you know what types of issues you might have if you have a prolonged QT interval? I'm sorry, what? Okay. Okay, yes, and so that can also be very serious, and if somebody is having a prolongation of their QT interval, we've heard that in report a couple times actually, there have been a few patients this year that have had that, they are going to look for a different antipsychotic. They're not going to keep them on that. And some of them actually are cause damage to the liver too, so we have to monitor that. And then if they're drinking on top of that, really not a good thing. I'm just going to stop quick and let's see. Just show you a little